Well, welcome to the second episode of the GU Cast Journal Club. Declan Murphy here from GU Cast. I'm joined in studio by one of our GU Cast Journal Club editors, Carlos Delgado. Welcome back, Carlos.
Thank you, Declan.
Very good. You enjoyed the first episode enough that you've come and joined us for episode 2 of GU Cast Journal Club?
Of course, very happy to be here. Thank you.
And joining us on Zoom, well, co-host Renu is not physically in the studio with me, but I'm delighted to say you're joining us on Zoom. Renu, how are you?
I'm good. Well, kind of good. I'm experiencing some old age problems. Bad back.
Your bad back.
Couldn't quite make it into the studio, so I'm excited to be here on Zoom for the second GU Cast Journal Club. This is exciting.
Oh, thank you so much for joining us with your bad back and all. And then our other GU Cast Journal Club editor, Elena Berg, joining us from Munich. Elena, thanks for joining us again.
Yeah, thanks for inviting me again.
So look, this first episode had fantastic feedback, and as we announced last month, we have this monthly GU Cast Journal Club that we're going to bring you, led by you two, by Carlos and Elena, who are senior trainees from Mexico, but working in Melbourne, and from Germany, respectively. These are supported by our partners, MSD, who are great supporters of many of our educational activities here in Australia through an unrestricted educational grant. So thanks very much to MSD. And Renu, I have to say, we've had fantastic feedback on this first episode. I mean, we thought, it might reach to certain people and be popular, but we've had great feedback, haven't we?
Yeah, no, and it's a great initiative, and the main point of it is really to highlight these key papers and the main takeaway messages, and really to critically appraise these papers. And we hope that it'll be useful for all listeners, but in particular for trainees, those who are preparing for exams, those who are really getting to the pointy end of their urology training. I think these journal clubs are such a great time-efficient way of getting that knowledge.
And that's what we're going to try and do. We're going to punch through 2 more papers today. Carlos and Elena will each lead us through brief summaries of the papers with strengths and weaknesses, and we'll dive in for a quick discussion. All done in about 30 minutes or so on your ride to work, your commute, cooking at home in the kitchen, whatever. What did you say, Renu?
Morning run.
Yes, morning run, exactly. Whatever it is, as you're listening to this GU Cast, we'll try and give you some take-home messages. So what are the 2 papers we're covering this month? First of all, we're covering the Translate trial, which we already covered in GU Cast earlier this year, but it's a key trial. It is truly a landmark trial in prostate cancer diagnostics, published in Lancet Oncology. Transrectal versus transperineal biopsy, the biggest powered trial of them all. So Elaine is going to take us through the Translate trial, so you'll get those key messages. And second, Keynote-564, again, another very important phase 3 trial that we've discussed a couple of times over the past 5 years on GU Cast. This is the key pivotal data that tells us the role of pembrolizomab immunotherapy in the adjuvant setting following nephrectomy for renal cancer. And this is really important, I suppose, especially for you urologists out there listening and watching. When you see your post-nephrectomy patient in the clinic for follow-up, you and I need to be thinking about, is this a patient who might benefit from pembrolizumab? So let's dive right into it. Elena, you're up first. Tell us about the Translate trial.
Yeah, so the Translate trial was presented at the Practice Changing Plenary at EU this year. The background of the trial was that we all know prostate biopsies have been traditionally performed via transrectal ultrasound-guided approach, but in recent years, the transperineal approach has been adapted by many centers and urologists, promising especially lower infection rates and less antibiotic treatment, while providing at least the same diagnostic accuracy. The goal of the Translate trial now was to compare the 2 approaches in a randomized and controlled setting for the detection of clinical significant prostate cancer, but also comparing side effects, tolerability, and patient-reported outcomes. So the trial was conducted at 10 centers in the UK, and patients with either PSA elevation or an abnormal DRE were included. Patients had to be biopsy naive, and they had to have received a pre-biopsy MRI. 1,126 patients were included and randomized 1-to-1 to either receive transrectal or transperitoneal biopsy, both in local anesthesia. It was a cognitive biopsy with an average of 12 systematic cores and 3 to 5 targeted biopsies per lesion in both groups. Patients with the transrectal biopsies received antibiotics pre and post procedure, while the majority of patients with a transperineal approach did not receive antibiotics. About 90% did not receive antibiotics. The primary endpoint was the detection of Gleason grade group 2 or higher prostate cancer. Secondary endpoints were adverse events like post-biopsy, including infection, bleeding, urinary or sexual function, and other patient-reported outcomes. Concerning the primary endpoint, a 5.7% higher rate of Gleason grade group 2 or higher was seen in patients that received the transperineal approach. It was found in just over 60% in that group versus 54% in the transrectal group, which was statistically significant. Infection requiring admission to the hospital within like 35 days after biopsy occurred in less than 1% in the transperineal group versus about 2% in the transrectal group. There was no significant differences in overall biopsy-related complications like urinary retention or urinary or sexual symptoms in general 4 months after the biopsies. But patients in the transperineal group more frequently reported post-biopsy that it was more painful and discomforting right after biopsy, while at 7 days it was the other way around, and the transrectal group reported more procedure-related symptoms. Serious adverse events occurred in about 2% in the transperineal group and about 4% in the transrectal group. So in conclusion, the TRANSLATE trial as a randomized controlled trial showed that transperineal biopsy led to a higher detection of Gleason grade group 2 or higher prostate cancer compared to the transrectal approach, while being safe to be performed in local anesthesia and without the need of antibiotics in the majority of patients.
Excellent summary. Punch, punch, punch. I love it. Renu, what do you think of that?
Yeah, fantastic, isn't it? And we did a podcast on this, and that was released just at the time when the embargo lifted on the publication, and just as it was presented at the Practice Changing Plenary at EAU this year. And what was that great quote that we had? We don't do a biopsy to avoid an infection. We do a biopsy to detect cancer, and this is kind of considered the holy grail of cancer detection.
You're so right. I love that comment. And I was the discussant on this at the EAU as well. And because we'd already recorded the podcast and it was under embargo, but we did sneak in a video clip into the discussion. And it was Richard Bryant who presented the paper. And because when people say, oh, what about the infectious complications? They don't seem to be that different, at least in these randomized trials. But that's why the primary endpoint was so important, Elena. The primary endpoint was not about infection. The primary endpoint was about cancer detection in like over 1,000 patients, all of whom had an MRI scan. So a real modern era. And as Richard Bryant memorably said, the reason patients undergo a biopsy is not to avoid an infection. It's to determine, do I have clinically significant prostate cancer? And that's why it's the primary endpoint, and everything else is secondary. So that was his very memorable quip.
But we also were of the view that a man doesn't have a prostate biopsy to avoid an infection. He has a prostate biopsy to either find or hopefully not find, clinically significant prostate cancer. And it really is all around the cancer that you find or don't find, hopefully.
And I thought you were very measured during that discussion role that you had, Declan, because, we've moved to transperineal biopsies for years here. And you asked that question, is it the end of the road for transrectal biopsies? And you gave a very measured... Maybe not.
I did get a hard time for that. People said you're too diplomatic in your old age, Declan.
Here in Australia, there is no road for transrectal biopsy.
Well, let me ask you that. I mean, you've been working here now for a few weeks. Well, you clearly haven't seen a transrectal biopsy, but I wonder, have you even met an Australian trainee who has even done a prostate biopsy?
I think
Australian trainees don't know how to do it,
Yeah.
If they go to the US to go and train for a while, they have no idea how to do a transrectal biopsy because it has not existed here. Mm-hmm. But look, why is this important, Elena, for people out there listening to this? Why is the TRANSLATE trial an important trial. Do you think this is sufficiently strong to mean that clinical practice should really dramatically change in favor of transperineal biopsy, and we should not accept transrectal biopsy? I'll be provocative for you.
Yeah, it is important because it really is one of the first randomized controlled trials in that setting. All the data we had were mostly cohort studies, so it really has this clinical implication. And we have to consider that the infections were a bit lower, even though almost no patient received antibiotics in the transperineal group, while everyone received antibiotics in the transrectal group. So there's also just a huge difference there.
Yeah, totally right. And I suppose we should acknowledge that there have been a few other randomized trials in this setting, and we won't go through everything in detail today, but I did go through them during the discussion at the EAU. But the reason why I think this one will be considered the definitive one, everything adds value in their own different endpoints, is the size of it. More than 1,000 patients, very contemporary, even run during COVID, actually. Everybody had an MRI scan. And I think, therefore, certainly this will align with practice in many, many countries around the world. And I'd put it to you like this. In the discussion at the EAU, I turned it around the other way. I'd say, well, what if transperineal biopsy was our standard of care? It's the way in which prostate cancer is being diagnosed. And interestingly, almost 100 years ago, that's how we did do prostate biopsy before ultrasound became available. And then say that transrectal biopsy was the newcomer on the scene because, it's easier to do in the office, maybe slightly less pain and so on. And would we accept that, this is faster to do and a bit easier, but the detection rate of clinically significant cancer is worse? Would we allow transrectal biopsy to replace? No, we wouldn't. We'd say, well, there's no way we can do that. The number one goal of a prostate biopsy is to detect clinically significant cancer. So I think that is it.
When you think about the timeline, isn't it? And if you flip it, just like you did when you were speaking at the EAU, it's a situation that we would never fathom, moving from transperineal biopsy to transrectal biopsy just because it's a little bit easier or it saves a bit of money. But it's interesting to think of it in that way.
And look, the reason I concluded at the end of the talk is it's not quite the end of the road, but I said I put a lot of caveats in there because, it's not that easy in many, if we just clicked our fingers and overnight every prostate biopsy in the world should be done transperineal, because it's not that easy. But what has been shown, and by the way, this is local anesthetic transperineal. So, we just have to push ourselves to get to that point, and we have to also improve certain aspects, because that was one of the criticisms, wasn't it, that the pain scores were a bit higher in the transperineal biopsy thing. So from a patient focus point of view, there are things to be done that will help disseminate maybe transperineal biopsy. It's also a little bit more expensive because you have to use a device, but again, there are ways in which that can probably be improved as well. But Elena, that was at the EAU. It was in the plenary session, so it won't be reflected in the current EAU 2025 guidelines. But of course, we'll see the 2026 guidelines at next year's EAU in March. Can I ask you to speculate? Already the EAU guidelines, I should say, are quite strong in favor of transperineal biopsy for infectious related reasons. But can you see the guidelines changing further? Now they'll be able to have the Translate trial to look at?
Yes, as you say, right now the guidelines state a strong recommendation to perform prostate biopsy via the transperineal approach, mainly due to the infectious complications. But I think we can expect that in the next guidelines we'll see also this oncologic aspect that we haven't seen until now, and the recommendation because of the oncologic aspect.
I think you're right. Renu, what do you think?
No, I agree. I think you're going to be right.
Love it. Translate done. So if you're listening to this one, it's very important that you know this data. And even though we will all accept some robust arguments why, it may be a little bit too ambitious to expect everyone to flip over, the data is the data, and it will stand for itself in a really well done randomized trial. So well done to Richard Bryant, Alistair Lamb, and everyone involved in Translate. We'll put a link in the show notes to our previous podcast about Translate. But Renu, I'll hand over to you to introduce Carlos to talk about the second trial, Keynote-564, and why we have chosen this for discussion in the Journal Club.
Yeah, so speaking of well-run randomized trials, I mean, we move from Translate now onto kidney, and Keynote-564, really a landmark trial. We've done, 2-3 podcasts on this already, but landmark trial for many reasons, but it is the trial that has shown an overall survival advantage for adjuvant pembrolizomab. So this is a space that's been an area of need for us in kidney cancer. You know, for aggressive localized kidney cancer, we have no adjuvant treatments. We basically just watch these patients for recurrence and then treat them. So this is a very unique trial that has shown this benefit. So over to you, Carlos, to present Keynote-564. This was presented at ASCO GU 2024, I think.
I think so. And previously presented at ASCO plenary in 2021. They presented a benefit in disease-free survival, but overall survival wasn't reached until the maturity of the trial, which was presented in 2024.
And I remember, of course, Renu, we had Tony Shueri on after he had presented the RPFS data, and we said, come back to us when you've got overall survival data. And he was on with his good mate, Alex Kudakov from Fox Chase. And then when the OS data, which you're about to discuss, came out, we had a further podcast with Alex Kudakov and Matt Ziebelman from Fox Chase. So we'll put links in there as well. But Carlos, over to you.
Perfect. So adjuvant therapy in localized renal cell carcinoma has historically been disappointing, with a long number of clinical trials failed to prove benefit in this setting. The aim of the study was to evaluate whether adjuvant pembrolizumab improves overall survival in patients with clear cell renal cell carcinoma at intermediate high or high risk recurrence after nephrectomy or complete resection of metastasis. This is a phase 3 randomized double-blind placebo-controlled trial. Inclusion criteria was patients with confirmed clear cell RCC who had undergone surgery within 12 weeks before randomization. And surgery could include partial or radical nephrectomy and synchronous or metachronous within first year after nephrectomy, complete metastasectomy. These include patients with intermediate to high risk disease recurrence or high risk disease recurrence. This is patients with T2 and nuclear grade 4 disease or sarcomatoid features, patients with T3 disease, or patients with T4 N positive or M1 NED patients with no evidence of disease. They recruited almost 1,000 patients. 496 patients received pembrolizumab, and 498 patients received a placebo. Intervention arm received 200 milligrams of intravenous pembrolizumab every 3 weeks for 1 year, and the control arm received placebo. The primary endpoint was disease-free survival, and key secondary endpoint was overall survival. The results at a median follow-up of 57.2 months showed a significant improvement in overall survival with the pembrolizumab arm. Overall survival curves separated around 15 months and continued to diverge along the course of the study. And at 48 months, overall survival was 91.2% for the patients on the pembrolizumab arm versus 86% on the patients of placebo arm. So an absolute benefit of 5.2% in overall survival. The risk of death was estimated to be 38% lower in the pembrolizumab group, and the hazard ratio for death 0.62 with a 95% of confidence interval and a p value of 0.005. Disease-free survival was also favoring pembrolizumab with a 64.9% on the pembrolizumab group and a 56.6% on the placebo control arm group at 48-month point. There were grade 3 and 4 treatment-related adverse events in almost 20% of the patients on the pembrolizumab group, and 21% of the patients discontinued pembrolizumab due to toxicity. Almost 36% of patients had immune-mediated adverse events related to pembrolizumab. Quality of life remained stable with no major deterioration. And major strengths of the trial, this is a very well designed trial. It's large and well conducted. Long-term follow-up is the reason why the study reached overall survival benefit. And they did a very good selection of patients, which at the end resulted in a positive trial. Some of the limitations are that some subgroups were underpowered, like the M1 NED patients, which led to a wide confidence interval in overall survival for these groups. Also, 21% discontinued the treatment, and also long-term management of patients who relapse post-adjuvant pembrolizumab remains uncertain. Also, some might argue that the control group was placebo, and that might have been a little bit unfair. Given that there was a positive disease-free survival trial with sunitinib, but it was really never a common practice to give sunitinib, and it's related to a lot of toxicity. So as take-home points, pembrolizumab is the first adjuvant treatment in RCC to show an overall survival benefit. Absolute overall survival gain is modest, but clinically meaningful. This is not a kitchen recipe. Benefits have to be weighted against toxicity, and patient counseling and patient selection remain crucial. This is a new standard, the new standard of care for high-risk patients after nephrectomy. And these patients really deserve at least to talk to someone who is able to give pembrolizumab, and also that is able to manage the side effects of this treatment.
Very nice, Carlos. I think you covered, absolutely all the main points of that trial, and really the first trial in this space for kidney cancer to show that people will survive longer with the addition of adjuvant pembrolizumab. But it's an interesting conundrum for us, isn't it? How do we select these patients? And does everyone who fit the Keynote-564 criteria, should they all be considered? What are your thoughts on this? How would you go about risk stratifying these patients? Obviously, the pathology becomes really important, doesn't it?
So I think that with time, we should better refine that patient selection, because I think, by example, there is some group of patients like the ones that have a T2 disease and grade 4, which are not very well represented. It's only 10% of the patients in this trial. That maybe it's better to just weight the toxicities, and just watch them. But still, future clinical trials are needed to better select these patients. And also, remains the question, what are we going to give if they recur after pembrolizumab? Okay.
Yeah, it's true. I mean, we have this problem in prostate cancer as well, but everyone always says give your best drugs up front and worry about that situation later. And it's looking more and more like pembrolizumab given up front seems to be, the thing to do in the carefully selected patients. Obviously, what we worry about is toxicity, and that is a real concern for these patients. And some of these toxicities life-threatening, or they carry that with them for the rest of their life, and so it can be a very difficult choice to make. And counseling patients can be very hard, because a lot of the patients that you're going to give this treatment to will have already been cured by their partial nephrectomy or their nephrectomy. So you're giving them potentially unnecessary treatment with toxicity and no gain.
That's right. That's almost half of the patients which are already cured with surgery. But still, this is a very like once it's with metastasis, it's not localized. This is a deadly disease.
That's true. And metastatic disease carries with it all the morbidity of those treatments as well. I mean, the other unique thing about Keynote-564 is that this is the only trial in the adjuvant space. I mean, there have been multiple other trials. We've got trials like Emotion 010, which was adjuvant atezolizumab. I think there was the Checkmate 914 trial that was Eapen. What is it about pembrolizomab that makes it so unique that this is the drug that seems to have that survival advantage when no other study has shown that before? That's interesting.
I think trial design is one of the reasons why this trial showed overall survival and some others not. Ipi-Nivo was given, I think, for 6 months. And also patient selection. This is really only patients with high-risk disease and only included clear cell renal cell carcinoma patients.
Yeah. And then I think it also highlights a couple of areas of need. There's a lot of work now going on in biomarkers. So there is one biomarker in particular called the KIM1 molecule, or the kidney injury molecule, which is a circulating biomarker. And that's shown some potential to further risk stratify these patients and help us select who may be the ones that benefit from adjuvant treatment. So that I think the work on that is fascinating. Declan, I'm sure we'll see more of that.
Yeah, I'm sure. What a great summary. I recall Tim O'Brien, one of my great mentors at Guy's, when he was looking, and he was a big kidney cancer expert, still is, of course, saying that when we're considering therapies in the adjuvant setting and we're considering toxicity, that you have to set the bar like so much higher because of the fact you just said that literally half of the patients, like you might have in the clinic, half of these patients will not recur. But if you give the drug to 100% of the patients, or 90% even, you've read the toxicity, like 20% of it can be very, very severe. So it's always that balance we're trying to get. And he makes that point, I think, very well, that the bar has to be higher. So for example, sometimes I know when we have this argument, Renu, and we say, what about the toxicity? And medical oncologists will say, oh, that's all predictable or manageable. Yeah, right. Tell that to the patients with the retinitis who can't drive anymore. Or myocarditis, or the one who's got diabetes for life now.
Diabetes for the rest of his life. Yeah.
And if you've got metastases, he makes this point very well, Tim O'Brien. If you've got metastatic cancer, you accept it. The bar is lower for the toxicity because you accept it because I've got metastases. But if it's in the adjuvant setting, it's just tough. So I'm not saying it's wrong, because it's right, but it means the discussion is much more nuanced, isn't it, to be trying to lay that out. Because, for example, if I'm the patient, I'm sitting there and you say, okay, I fit the inclusion criteria. Let's say I'm just a PT3, grade 3, 4, the ones that we worry about, the unmet need patients. And you say, well, the option is you can have pembrolizumab now. We're going to give it to you now in the adjuvant setting, or you can wait. And what then? Because then, in the control arm of this trial, of course, not every, but less than half got in immunotherapy afterwards. So what if you said, well, I won't have it now, but I know I can access Ipi-Nivo or Len-Pem or whatever, one of the great doublets that works so well. So I suppose that's still the discussion to have with patients because, sorry, Renu.
That's right. And it was one of the criticisms of the trial was that not everyone who progressed on the placebo arm got the treatment. But then the counter argument is that, well, that's the real world situation. Not everyone who progresses will get systemic treatment. It'll be based on their risk stratification. But you're right, when there is an option to have something on the back end when patients progress, you do really have to take the toxicity of adjuvant therapy very seriously.
Really good. But why is it important? Why is this discussion important? Elena, I might ask you that question. So, I mean, here you have 4 urologists talking about this. I'm sure there are GU medical oncologists shrieking into their AirPods as they listen to these 4 urologists.
And urologists.
Bumbling along, But the reason it's important, the reason we're talking about it is because these are all urology patients, of course. These are all patients who've just had surgery for kidney cancer. So Elena, it's a conversation I certainly never had when I was a trainee or doing kidney cancer, but is it a conversation that you and European trainees are aware of now if you're following up the post-nephrectomy patient in the clinic a few weeks later with his or her pathology results? Are people tuned into this?
Yeah, definitely. In Germany, we have a special situation that we will be the ones doing the systemic treatment as well after the surgery. So we, of course, tell them surgery went well. We could remove the tumor, but we have to talk about adjuvant treatment. And then we have to inform patients about their individual recurrence risk, also inform them about the benefits, but also the risks of adjuvant treatment. And in the best case, have like a shared decision making and a patient selection for this treatment.
What do you think of that, Renu? Maybe we should do that. We could start. You can start off the urology given Pembro program at Petermac.
No, thank you.
No, thank you. Again,
it's not part of his fellowship.
Elena can do it.
The other heart sink moments for me when it comes to kidney cancer are the non-clear cell pathologies.
Yes.
This again remains a huge area of need, and these patients have very aggressive cancers, and you really wish there was something you could give them. And, so much important work still to be done in kidney cancer.
Yes, and Tony Shueri and all his fantastic collaborators on Keynote-564 are definitely doing some of that, looking into these rarer cancers. But in the meantime, I hope our audience enjoyed that this month. But I think these 2 papers, Translate for prostate biopsy, Keynote-564 for adjuvant Pembro, are very important papers, landmark papers. And that's why we feature them on this episode of the Journal Club, Renu.
Yeah, two great summaries, by the way. I learned a lot.
I did. And so congrats to you, Elena Berg, joining us from Munich, and Carlos Delgado here in the studio in Melbourne. Thank you for putting those together. They're fantastic. So as I said, we've had great feedback. I know there are people out there sharing these episodes out in their WhatsApp groups as they're preparing for exams around the place. We've got a list now. We've got a shared spreadsheet of a bunch of papers like this from the relatively recent past that we'd like to highlight on the Journal Club. But we also have some classic landmark papers from decades ago that we would love to feature. But if you have papers out there in your Journal Club or your trainee group, or you're already an established boss who says, how come nobody talks about this paper? Please do reach out to us, get in touch, info@gucast.org, or you can always track us down very easily on socials. We would love to hear from you. And Renu, we should thank again MSD, our Journal Club partner. MSD have already been very great partners of ours on GU Cast for a few years, but it was their idea to help put together a Journal Club. And so hopefully that's well received.
Absolutely. Thank you, MSD.
Thank you. So that's all we have time for on this episode of GU Cast. We will be back again with the regular GU Cast very shortly, and GU Cast Journal Club will be back next month with another edition. Thank you very much indeed.
Nice.